Good afternoon, everyone. I'm just waiting for the slides to come up when I do it here.
Let's go, if you go that way, I think. There you go.
Okay, here we go. Thanks. So we're moving from the testicles to the brain now. Thanks to our colleagues for that comprehensive guide to neurology. So my name's Tom McInerney. I'm I'm a GP in Crooks, and I'm one of the neurology cases reviewers alongside two of my GP colleagues in the city, John Dixon and Emma Story. And as with urology, we work alongside two of the consultant neurologists at STH, and we have quarterly meetings where we sort of review activity and talk about the sort of information that we think would be helpful in primary care to help guide us in terms of managing patients who present with neurological problems. There is top 10 tips, which is on the PCS Cases website, which is very useful. I've just put the headings here, but there are explanations and guides in terms of what to do and how to manage these when people present with these symptoms or these presentations, which are useful, I think, and worth looking at. So it's definitely worth having a link to that. But today I'm going to focus on headache, I guess for two reasons. First of all, it's something that we see a lot of in primary care. And secondly, we see a lot of it in the neurology cases. So we get a lot of referrals with patients with headaches. And as has been said before, I think Rowan mentioned about the sort of purpose of this work, as Emma said too, it's not about redirecting your referrals away from secondary care. That's not what cases is about. It's about trying to ensure that it's a sort of more standardised approach when we do refer to neurologists in this case, so that they've got all the information that they need in order to ensure that the patient has the best possible sort of outcome in their outpatient appointment. And also that you don't then get referrals sent back to you, which just, I know how frustrating that is in terms of generating more work. So some of the slides in this presentation are from a presentation that one of our consultant neurologist colleagues uses to present to GP registrars. So we're going to talk a little bit about how common headaches are, and as presentations in primary care, what are the typical causes, and a focus particularly on migraine and tension headache, because I think often we see patients referred through to secondary care who have migraine, and often patients, as we'll see later, are even referred under the two-week wait referral to neurology who actually have migraine. And it can be difficult, I think, as a GP when you're sitting in primary care, trying to sort of weed out those patients where we think, actually, I'm concerned there's something really serious going on here, as opposed to trying to manage something benign like tension headache or migraine, which can be complicated and really debilitating. So I'm going to talk a little bit about brain tumours as well. So headaches are common. So I think these statistics are from about 2019, so just before the pandemic, a bit out of date now. Anything up to 5% of GP's workload. Lots of people get migraines in the UK and internationally. And again, that figure of 14% is from cases data, but I think is about 4 or 5 years old now. When it says my experience, this is the consultant colleague in her outpatient clinic in Bassetlaw and at the Hallamshire. So it's about 20% of referrals, and 32% of those referrals turn out to be migraine. And then of all the patients that are referred, she sees the two-week wait suspected cancer referrals, and about a third turn out to be migraine. So who gets migraine? Lots of people. I'm sure there are a number of colleagues in here today who suffer from migraines. It can occur at any age, usually starts when people are teenagers, and then peaks in sort of early middle age. Initially more common in boys than girls, and then that changes, and it's much more of an impact on women. And lots of implications in terms of people's lives, their working lives, the economy, etc. So there's a real kind of onus on us, I think, to try to support people to manage this condition in order to improve the quality of their life and, of course, reduce the impact on the wider economy and their family. So lots of causes of headaches. Some of them are really small print, others are much more common. As I said, I'm going to focus on migraine, tension headache. I'll talk a little bit about medication overuse headache. But again, with a caveat that I get that this is difficult. I mean, we had a case at my practice about 4 years ago, I think, where I think 4 of us, over the course of about 4 or 5 weeks, saw a young woman with headache. And we did all the usual stuff in terms of she was appropriately examined, that was all documented. And the working diagnosis, I think, until consultation number 4, was this is a tension headache, and of course, she had a medulloblastoma. And subsequently, we received a complaint, which was escalated to NHS England. And we went through, of course, as you would expect, the whole SEA process and discussed it. And we genuinely reflected, we thought that at each of those consultations, we wouldn't have done anything different on the basis of what we saw at that consultation. But obviously, by the time she presented the 4th time, it was a whole discussion around the complaint really was about why didn't you scan her sooner? So, you know, that's something that I'm sure you face in terms of questions from patients, and it's deciding who should we scan, when is it appropriate to scan, and obviously the rest of the time really just managing people without scans. Hold on, I don't know why it's doing that. Okay, apologies for this, I'm just going to keep moving. So, in terms of classification of migraine, there are some specific criteria from this International Headache Society, and it's particularly about, you'll be familiar in terms of it's often unilateral, often it can be associated with visual disturbance, for example, but people can get other types of symptoms. It can be really severe. So I think that's the thing that when patients come, they often describe this, when you ask them about the headache, you know, what does it feel like? They say, I really just need to lie down in a dark room. You know, I need to get away from everything. I can't do anything. I can't function. As distinct from, I get a bit of a tight band around my head. It gets worse as the day goes on, you know, and it's really throbbing by the end of the day. Migraine's not like that. It's different. And usually, they've either got nausea or vomiting or photo or phonophobia associated with that, and obviously there's no other underlying cause. It's doing that again, sorry about that. So often people have a prodrome. So when you ask people with migraine, they'll say, I know when it's coming on. You know, I could sense, especially if they present to you and it's happened to them a few times, they'll be able to say to you, I can tell that something's coming on. I start getting a twitching, or I feel a bit sick, or I'm sweating, or it can be things like I crave certain foods, or I start to become irritable. And of course that's very vague, because all of us can feel hungry at times or feel irritable in the day, but you know, then it leads on to about a quarter of people get the aura, so the classic aura that we read about in textbooks. And then they obviously get the main attack, which is usually pain, sometimes vomiting, often with nausea. And as I said, the thing that makes them better is lying down and often going to sleep, and that tends to take it off. And then sometimes people describe afterwards a sort of hangover effect, so feeling sluggish, tired, and just generally kind of washed out. How do you treat it? Lifestyle, as ever. I don't know how much time you spend talking to patients about lifestyle, but you know, with a whole kind of range of presentations that we see in primary care, particularly probably about a quarter to a third of presentations in my clinical practice are to do with mood problems, anxiety, stress, low mood, sometimes associated with headaches or other symptoms. When I ask people, I say, so tell me about your life, what's your work like, how are things going at home, how's your sleep? Do you eat well? Do you do any exercise and so on? Often they're not looking after themselves, and that's really, sometimes it's very difficult for them to look after themselves because they're living in really challenging circumstances. But it is important to ask about that because that can go a long way to managing these types of headaches. Then we've got acute treatments, abortives, and then we've got obviously prophylaxis. These links will go up at the end and you'll be able to have the slides afterwards, as Emma was saying earlier. So treatments, well, as you probably know, people try simple analgesia. They try paracetamol, they try ibuprofen, they try migraine relief, these types of medications. We prescribe them triptans, and triptans can be very effective in terms of stopping a migraine before it gets much worse. But there are also limitations with triptans, so we can't just keep, if patients are using them a lot, that becomes problematic, and it can actually lead to worsening headaches, so it actually causes the problem you're trying to solve. Don't forget, this is in the guidelines and the links that you'll be able to see later, you can combine analgesia with antiemetics. They can be very helpful. Try and avoid codeine for obvious reasons. That's the usual prime suspect in terms of medication overuse headache. So you talk to patients, you say, right, you're getting all these headaches. I see in your repeat prescription there you're taking, how many codeines are you taking, or cocodamols? And it turns out that they're using that regularly, they're having 8 a day. And really it's trying to, I'll come to that a bit later, it's trying to sort of educate and support patients to wean themselves off codeine, whether it be for their back problems, their arthritis or whatever, because that's often what's driving the headache. There are also, with triptans, don't forget, there are different methods of administration of triptans, so sprays, intranasal, not simply the tablets, there are the wafers as well, so I find patients respond quite well to I think it's the rizatriptan wafers, they can be very effective. And obviously watch frequency, so talk to patients about how often and when they can use this medication and check in with them, follow them up. So in terms of, you've discussed the lifestyle, you've tried to encourage them to do all the right things in terms of their sleep and not spending too much time on screens or cutting back on alcohol, caffeine, etc., doing a bit of exercise. And then you're thinking about medications. So we've talked a bit about already the acute medications. Now we're thinking about prophylaxis. So again, there's a guide in terms of, which is on a later slide, in terms of sort of, well, what constitutes chronic migraine versus intermittent or just acute migraine. And I guess for me, it's not about sort of hard and fast rules and saying, oh, well, you've not had this many this month, so that doesn't count. It's about impact. It's about asking people and talking to them about how debilitating these headaches are. And if they are, if they're coming frequently, if it's impacting on work and their life, usually if they're consulting you, then things are getting to a stage whereby it's really impacting on their life. So I'm not too prescriptive about, when I start prophylaxis if it's impacting on someone's life. It doesn't have to be a certain number of times. Beta blockers, simple one to start with. Amitriptyline is the other one commonly. So propranolol, amitriptyline. Obviously you do the usual things in terms of counselling patients about the side effects of these drugs. By the time you start getting into topiramate and sodium valproate, it's getting a bit more complicated. In my experience, topiramate has a lot of side effects, and it's really important. What the neurologists find is that by the time they get to the neurology outpatient clinic, and it may say in the letter, oh, they've tried topiramate or whatever, often when you ask patients, or they ask patients in clinic, if we haven't done it, so how long did you take the amitriptyline for? 3 days? Or I got dry mouth, or it made me feel really hungover in the morning. So it's important, the more I think that we prepare patients in terms of saying, right, this is what this tablet, it might make you feel like this, the more we kind of preface them trying the medication with warning them about potential side effects and the fact that most of these side effects will be temporary, they will resolve. They're more likely to stick with it, and in turn they're more likely to get a therapeutic response, and so consequently get better management of their symptoms. Sodium valproate, obviously not in women who could become pregnant. Candesartan's a good one. I find that's the ARB for hypertension. That's often really well tolerated, I find, and patients can, put up with it and find it's quite effective. So that's licensed too. And then you're into more exotic territory in terms of sort of things like Botox and monoclonal antibodies, which obviously take place in secondary care. In terms of, there's a really sort of important, if there's one thing I could ask you to take away from this talk today, it's about when you're trying prophylaxis, if you could try 3 agents with the patient before you refer them. So if you're confident of the diagnosis, try 3 different drugs and try to ensure that the patients take them for a reasonable amount of time and titrate them up as much as the patient will tolerate, basically. And obviously that can be quite labour intensive because it involves follow-up. It's a number of appointments, but if we do it right, then these patients never need to go anywhere near neurology, and most importantly, you give them their lives back because they can actually control these debilitating headaches. When you do come to refer, it's really helpful. This is probably one of the key things that we get back from the neurologists. Can you put in your referral letter which drugs, for how long, at which dose? Because that means when the consultants are sitting down with them, as Emma was saying earlier about meeting the gynaecologist, if the diary's not been kept, you have to send them away again for 3 months. If on the referral letter it states which drugs they've taken and for how long and at which dose, that gives the neurologist something to work with in terms of where they go from there. Which is what I've just said. So again, this is the definition of chronic migraine, about someone experiencing 15 headaches a month. Okay, I saw a patient this week who was telling me they get the headache every single day. So some people do present with that, but if someone was telling me they were getting 10 headaches a month, I would still treat them with prophylaxis because I think that's a lot. With someone who's experiencing 1 a month, obviously you're going to go for abortives so that they don't have to take a tablet every day. But I think it's for you to decide in conjunction with your patient about what's appropriate. Obviously ask them if they're taking any existing painkillers. Are there things that they're taking that could be causing the headache? Too often, especially in, I think in older patients particularly, how many of them are left on repeat prescriptions of cocodamol for years? And if nobody checks and nobody asks, they just stay on it and we keep prescribing them. So it's really important to sort of think about that, when we have our structured medication reviews and so on, if you have time for those. If you try the 3 different agents as prophylaxis and it's just not working, then obviously refer. And that's the point at which we really need that information in terms of what you've tried. I think when you saw the statistics at the beginning in terms of number of referrals that are sent back to GP by specialty, we send very few back, so most are sent straight through to the neurologists. And actually I think that reflects something that one of the consultants has said before in our supervision meetings, which she takes referrals from South Yorkshire and Bassetlaw, so it's beyond Sheffield. And in their experience, Sheffield GPs tend to put in this information. So there is the sense that lots of colleagues in the city are actually very confident with this and you're managing headaches well. And they can do these more exotic interventions in secondary care. So medication overuse headache. You'll all be familiar with this, and I think it's, just as I've said already, I won't dwell on this, it's if you see patients on repeat, particularly opiates, then ask them about it, try and get them off it really. And it's much more likely in your patients, with not just cocodamol, but Oromorph, tramadol, those kinds of drugs, which ideally we want to try to get people off if we can. And certainly if you're trying to treat migraine, it's really important to try to get them off these drugs first. And I get that's not easy, it's difficult. It's difficult to try to persuade your patient with chronic osteoarthritis pain to stop using the codeine, but it can be done and it's important. So if they're presenting to you and talking about these really debilitating headaches, it's very helpful to talk about the regular codeine use and trying to reduce that. And also tell them when you're doing that their symptoms are going to get worse before they get better. So again, it's that thing about counselling people really appropriately in advance, so when it happens they know what to expect and they're more likely to be concordant in that case. Tension headaches. So, you probably have experienced these certainly yourself, but these are really common, I think, when patients present, and these can be referred to neurology as well. We do see these being referred, and they're very distinct from migraine in terms of how they present. So it is more diffuse rather than being focal and unilateral. It tends to be more mild, moderate. People aren't saying that they need to go in that dark room and lie down. And it tends, people often describe, a kind of sense of a tightness around the head. My head feels like it's pressured, like it's going to explode. But they can still function, tends to get worse as the day goes on. There are no red flags, and it's really about talking to them about all that lifestyle stuff that we talked about earlier, and also screening for depression as well. So red flags, so the brain tumours, the medulloblastomas, again, these are rare, but obviously every person who sits, every clinician that sits in primary care, when a patient first presents, it's part of our thinking, as Magdi was saying earlier, to exclude. We're always thinking about what's the worst case scenario here, what could be the most serious diagnosis, and try to exclude that in our, just simply by taking the history. So Fiona, the neurologist colleague, has got this acronym, and it's really about thinking about, so in terms of sort of neurology red flags, going from the top, systemic symptoms. So if someone's systemically unwell with a serious headache, clearly you're thinking about something completely different. You're thinking about potentially meningitis, meningococcal septicemia, that kind of thing. Any focal neurology, so anyone with a headache and focal neurology, your index of suspicion is up. You're thinking, there could be something more acute going on, obviously, like a stroke or a bleed, and potentially about a space-occupying lesion. When someone's older, obviously, disease is more prevalent as we age, and therefore it's important to think about that. Temporal arteritis is important to think about, the tenderness, particularly over the scalp. The medical textbook, classical thunderclap, sudden onset, really severe, worst headache I've ever had. You're thinking about subarachnoid hemorrhage. If you can, I don't know how confident people feel with looking for papilledema. So in terms of looking, doing fundoscopy, I think it depends. I think in my experience in my career, it's just the more that I do it, the better I get at it. So really, obviously I don't dilate pupils in my consulting room, but I think it is worth doing and just checking. Yeah, thanks, Emma. And then, that's a bit more. That's a bit more small print. I'll just move on. Yeah, progressive headaches and thinking about pregnancy. Okay, brain tumours are really uncommon. About 3% of all cancers. As opposed to what we heard earlier about prostate cancers. 5,000 new cases of neurological malignant tumours a year in the UK. In your career, statistically, you'll see 5 or less. So I've seen 1. I think 2 in my career so far. So we don't see these often, whereas we see migraine a lot. We'll see migraine, every week. And they tend to present, yes, with headaches, but often with seizures and focal neurological signs. And it's very few of those patients that present with headache, the proportion of them that will actually have a space-occupying lesion is very small, 1 in 1,000 on average. So who would you refer for imaging or refer on to neurology? Not necessarily just doing an outpatient referral, but potentially speaking to the neurology registrar on call or referring to the medical assessment unit. Obviously, sudden headaches, headache where you can see changes at the back of the eye, any head trauma, any kind of confusion, new cognitive dysfunction, any other kind of neurological deficit, and someone obviously who is systemically unwell with fever. Yeah, so red telephone, refer. Also, you need to consider patients, for example, who are HIV positive, because there can be particular complications there with things like toxoplasmosis. Persistent morning headaches with nausea can be a red flag, and any symptoms of giant cell arteritis. So that would be about doing the bloods and acting accordingly. And anyone over 50, just generally with a new headache that's kind of, we said earlier, migraines tend to start in adolescence, young adulthood. So it's just about being cautious. Okay, so when you're making an outpatient referral rather than one of those acute referrals, have you checked the fundi? Have you checked the relevant bloods? Have you asked about medication, done the lifestyle stuff? Have you tried at least 2, ideally 3 preventatives? And if you do refer, please put all the information in the letter. That's really helpful. And there's the references to the British Association and to the NICE guidance where you'll find much more detail. Thank you.